Good evening, everyone. My fellow Foxians, welcome to this 12th episode of Gyan Pravah, which means a flow of knowledge, a unique podcast series which is conceptualized by our dynamic president, Dr. Sunita Tandulwadkar. These podcasts, they have no hassles of registration and they have few viewership and they're treasure troves of knowledge and inspiration for all of us 45,000 Foxy members and youngsters. So I will be your host for the ninth of every month, presenting you personalities who have worked for women's cancer. Today's podcast features the UK vaccination program, and this is right after the World Cancer Day, which all of you have conducted these awareness programs all over India on the 4th of February. Before we begin our podcast, it's my pleasure to introduce Madam Dr. Sunita, who is the President Foxy, who took over just a month ago and making all of us change our approach towards our patients with a more holistic approach, impressing upon prevention, which is so important for healthy women. Dr. Sunita is the head of the Department of Obs and Gynae and the chief of IVF and Endoscopy Center at Ruby Hall Clinic, Pune. She's the founder and medical director of Solo Clinic IVF, a center for excellence in infertility and endoscopy in Pune, and founder and medical director of Solo Stem Cells, a stem cell research and application center in Pune, and Alive Wellness Clinic. And she's had extraordinary achievements, being the first person who actually made the India's first stem cell baby and the world's first in 2018. And she is right now, she's the president of Foxy. This is a large organization of 45,000 plus members. And she's also the president-elect of ISAR. She's the founder president of the Society of Ovarian Rejuvenation, past president of the Endoscopy Society. She's the past president of the Pune Obs and Gynae Society, and she's also the chairperson and the founder secretary of ISAR. And she has been a board member, and she's also a reviewer despite her busy schedule. She's also the editor-in-chief of the IGGE and reviewer and advisor of the Journal of Human Reproduction Science. And
Thank
she's
you,
authored
Sarita.
many books and
Thank
publications.
you. Thank you. Thank you so much. Professor Wang, thank you so much for joining us. Sarita will give your broad introduction soon. But most important thing is about this podcast series. Foxy works, our Foxy is a 75 years old organization. And one need to be fortunate to come so late so that it is all well planned. The previous presidents have done amazing job. And now these 46,000 gynecologists with 286 societies, our structure is beautifully performed. And 30 committee chairperson is a very, core of our Foxy. Now, every committee chairperson has been working in their respective committee for 3 years. They do dedicated various activities. So this time I thought these 30 committee chairpersons can take one day each, and in a year they can have 12 broadcasts. Now, in this podcast series, they can choose academician from the same field, non-academic, maybe a philosopher, spiritual guru, politician, social worker, anyone, depending upon what is their interest. There is no restriction. And that's why we are getting variety of the faculty who highlight somewhere academician, somewhere from a different background, Indian, international, 11 podcasts. With every podcast, the viewership is increasing. And that shows the strength every chairperson brings in creating this podcast, in making this broadcast. In Foxy, these committee chairpersons will be the future leaders of Foxy. And they learn this leadership quality. They are creative, they are passionate, they are academic, but they have given their valuable time for the organization. And I think this platform of a podcast is where the Gyan Pravah series, 8 p.m. every day, they are adding so much to our Foxy presidential year. So I'm thankful to each and every chairperson. You are amazing. And Sarita, let me talk about you because you became the chairperson along with me now. Her first year is 2025. But in these 15, 20 days, she has done such a amazing work. And on 4th of February, World Cancer Day, I had just a wish that the all India, every society, they release our one of the presidential project, which is called Do Tike Jindagi Ke. And the way she has worked communicating with all presidents, secretaries on an email, on a phone call with the follow-up. And I'm sure once her news bulletin special, because the work has been done so huge that we need to come out with a special report for her. And I'm sure you will make everyone proud. You have done amazing work. And Sarita, what I know in 1 month, I know 3 years, what a collective work you will do for every president and
Thank you.
for so I congratulate you. I wish you all the best, not only for the podcast, but your 3 years tenure. And Professor Wang, it is lovely to be with you in this frame. The amount of work you have done for a HPV, I think Sarita will be able to tell us more about it. But thank you for being on a Foxy platform.
Well, thank you for your kind words, Dr. Sunita. And well, Sarita, I've known now for I don't know how many years is it, 14 years or more?
Yes.
And
Yes,
yes,
more than that.
I agree with
Yeah,
all
15
of your
years.
comments about her dedication and hard work. That's definitely true.
Fantastic.
And anyway, we'll
Yeah, thank you so much, madam, for the encouragement and the support and the vision that you have. That it's just amazing. I think with we there's so much interest among all the Foxy members that I know cervical cancer we will eliminate from our country very soon. So introducing the Miss Theresa Freeman Wang. Miss Theresa Freeman Wang is a consultant gynecologist and colposcopist working at the Whittington Hospital in North London in the UK. She has extensive experience in teaching and training colposcopists and quality assurance of cervical screening. She has been the immediate past president of the British Society of Colposcopy and Cervical Pathology, and she has contributed a lot to the courses and to the academic material that you see on the BSCCP website. She is the president-elect of the International Federation of Colposcopy and Cervical Pathology, and she's a life member of the Indian Society of Colposcopy. She's been to India many times, and she loves being in India. Her recent focus has been on establishing management guidelines for multizonal intraepithelial neoplasia and expanding the scope of the IFCPC training courses. Her other interests are travel, history, theater going, and spending time with family and friends. And she's a great friend and very good, and she's a very good teacher also. So Theresa's
So it's lovely to have you, ma'am, and Professor Wang. And the protocol is, since it is a dialogue between both of you, I will be joining the other link where all of us will be watching you. Thank you.
thank you.
Thank you, madam. Thank you for joining. So Teresa, UK has the longest running HPV vaccination programs. So just tell us what about when it started and what were the initial problems. So we just had this, the TKs in the KK. I was telling about the HPV vaccination. So in a few months ago, there were a lot of anti-vaxxers, and there was a lot of hesitancy amongst all the gynecologists, especially about this problem and how the public will face. So what were the initial problems that you had, and when, so tell us more about the vaccination.
Yes, so I suppose one thing to say about HPV vaccination and the United Kingdom is most of what our chat and discussion is going to be really relates to England, though we have more data from Scotland. So the United Kingdom comprises 4 nations. And even though we're a small country, each of those nations has slight nuances or differences in its program. But broadly speaking, the HPV vaccine across the 4 nations, across the United Kingdom, started in 2008. So we were one of the first countries to have vaccination, Australia obviously being the first. The issues that we had are slightly different in the different areas. So in England, one of the problems we had is that we, until only a few months ago, actually didn't have a national register. So when the program started, there was a register for vaccines, and then there's a separate system for the call and recall of cervical screening, but the two weren't linked. Whereas in Scotland, which has a unified and much better system overall, it has always been linked. And the advantage of that is that they have therefore been able to give us the information, the data that shows the value and the success of the vaccination program more quickly than that's been possible in England, Wales, or in Northern Ireland. The main program is a community-based program in this country. So it's free for all as part of the National Health Service. It is predominantly, initially it was the GP practices, and it was a schools-based program and still is a school-based program. And in 2008 until 2019, it was only for girls. And it was year 8, so that's the 12-year-olds. And there was a catch-up program for those youngsters up to the age of 18 because they're still in school. So it has, in our country, been a schools-based program. It has been possible, though it's not necessarily well advertised or understood, that all eligible people can get their vaccine from their general practitioner by making an appointment. And all, excuse me, so boys were started on the program. I think it was 2019. And anyway, everybody now, if they're under the age of 25, can access the vaccine via their GP if they're no longer at school.
Right. So how does it work in the school? So do you send out a consent form and information to the
Yes,
parents?
so the information, so there's information both online and leaflets and an education program. There are community-based nurses that go into schools when they're offering, for example, the TB and the other vaccines. And then year 8, the children are all sort of gathered on a particular day, which is pre-organized as part of the program, and they go and get their vaccine. It requires the permission of the parents or a parent. However, we also have something here called Gillick competence. So if a young person who is under the age of 16, but if it's deemed that they have the appropriate understanding, they can override that if they wish. But obviously, the preference is to go via parental consent.
Right. So were there problems initially? How was the acceptance to the vaccine?
So
the
the
parents?
acceptance to the vaccine initially was not great. And as I'm sure has happened in other countries, there was a huge furore. I think when it soon after it first started, there was a young child that died. And it was said, oh, it was because of the vaccine, and it caused complete kerfuffle. But it turned out that this poor child actually had an underlying heart condition, and it was, after a full investigation, it wasn't related to the vaccine. There were also various things of people fainting and so on, and having, for want of a better term, sort of hysterical reactions. And that seems to have subsided with much better education and awareness, and also by staggering the way the appointments are done rather than getting everybody in a group together, all waiting around. So those are some sort of simple interventions that made a difference. And over the years, there have been, I mean, from a professional point of view, there has been a lot of data and studies looking at the complication rate or side effect profile. We have a separate registry, so if there are any adverse incidents, those are reported. But there hasn't been any evidence that the vaccine or those that are vaccinated have a higher risk of any serious adverse complications. But that remains a challenge, essentially. Coverage before COVID for the vaccine program was very good. So it had reached over 90%, and everybody was very content with how that was going. Obviously, during COVID, there was no program. And since COVID, we have been aware of more vaccine hesitancy, and the coverage in some areas remains quite low, in the sort of 69-70% range, rather than in the 80 plus to 90 plus range, which it was before.
Right. So this before the vaccination, so does the nurse give out some forms to fill with the history and their details before the
Yeah, so
vaccination
as far
date?
as far as I understand how the program works, so before they're coming out, there will be a questionnaire sent out. There is information on them, and you know, people have smartphones and various things these days, so there's access to those sorts of materials. There's a consent form which the children have to return to the school, and then that goes to the nurses. So they have a list of those people who have given their permission. I can't say that I have personal experience of what they do if people say no, but my understanding is that there may be further discussions, really just to see if one can allay those concerns. I think one of the issues that was highlighted in terms of the vaccine hesitancy anyway, is that sometimes in terms of a school program and the nurses coming out, there isn't sufficient time or support if people have queries, because obviously there's an expectation that you're going to get through a set number of people in the day. But my understanding is that by and large, the community nurses are quite knowledgeable, and the schools and the program that they have set up seems to be showing that even now, as I said, although overall coverage has dropped post-COVID, that in the last year or so, because I was just looking this morning actually at the latest figures, that there's been about, between boys and girls, between a 3 to 7% increase in vaccination coverage in the last couple of years. So it's heading back in the correct direction, though it is taking longer than people expected.
So tell me about the vaccine you've been using, and have you shifted to the single dose
So the
between 9 to
original,
20 years?
yeah, so initially we started with Cervarix, which, as you know, is against type 16 and 18. And then I think it was about 2012 we changed to Gardasil 4. And that was the case until 2023, when we've changed. Now we use Gardasil 9. So that's against the 7 HPV types, plus 6 and 11. And the data, again, is so encouraging, because there was a paper from Scotland, I think, in the last couple of years, and there was also a paper probably about 3 years ago now, looking at England specifically. And that has shown that since the vaccine program, that not only have we seen an overall 87% in cervical cancer in that cohort that have been vaccinated, but we've also seen a significant decrease in the women with CIN3. So the interesting thing from a colposcopy point of view is that our clinics are still full, but they're now full with people with HPV and low-grade changes, or older women with persistent HPV, but we're not really seeing very much high-grade disease.
Right. That's interesting.
Yeah, and it's a different challenge because now we have a large population of older women, and some of them who
Mm.
are just having their first primary screen test sort of, at about 60 with their HPV, and we can't see very much. So there are different challenges, but what the vaccine program is out to do, both in terms of reducing cervical cancer and CIN3, it is definitely, the evidence shows it is doing that.
Right.
And
So
I
how,
would go on. Sorry, I'd also go on to say that for those women born after, say, September 1995, that cohort of women, we can probably say that we've nearly eliminated cervical cancer in that age group, in that who've been vaccinated.
right, that's wonderful. So how is vaccine hesitancy managed? What do you do when they don't, where they just drop out of or they finish the school and they're not finished
Well,
their vaccination?
that's a
Or
problem,
they're,
and we don't have a good answer to that. So
Hmm.
I'm always open to ideas from other countries, because one of the reasons I think that the catch-up program was less good is precisely that. So if youngsters leave school early, then there isn't a straightforward way to access, or for them to access care, or to access the vaccine. And there isn't a useful or a particularly good way of getting their attention and getting them to attend for their vaccination. So the honest answer is other than campaigns which are rolled out just as your cancer awareness. So here we have Cervical Cancer Awareness Week, which is usually the third week of January. And then we put up posters which go, in London anyway, they're across the tube system, so across the metro, the buses, everywhere. So that we have those sorts of campaigns that run, increasing people's awareness and the ease with which one can get a vaccine, informing them that, they can still access it via their GP. But other than those sorts of programs, and particularly in our increasingly cash-strapped world where councils don't have money for a lot of campaigns and things, it becomes increasingly difficult. One of the things we had until last year, you may have come across, there was Joe's Cervical Cancer Trust, which was a
Yes.
charity that put out a huge amount of materials and did a huge amount of charitable work to engage and educate the public and encourage these things. But sadly, they went bankrupt, so we don't have that facility
Okay.
anymore.
Right.
There is another charity called the Eve Appeal who have taken over some of that work and those materials, and are in the process of peer reviewing and updating them. So we hope to have some resource back, but that has been a blow for that aspect of the campaign.
Right. Yes. We really need somebody to, in the public, to keep motivating them all the time.
Yeah.
So did you have any anti-vaxxers? And do they,
Yes, we do. I mean,
initially you made
we didn't have as huge an issue with anti-vaxxing, interestingly, as say happened in Japan. And for a time, there was a large anti-vax campaign also in the Republic of Ireland, where it was more vociferous anyway, I'd say that. So we haven't had a hardline anti-vax specifically for HPV vaccination. There are clearly that group of individuals who are against all vaccination, and
Yes.
particularly following COVID, we did have that. So there is a fair amount of overlap. And, in fairness to them, there's that distrust of all governmental things that are imposed upon people. And for those of us who all did get our COVID vaccine, the way the message changes doesn't help. So I can only speak to that. So initially, we all had to have the COVID vaccine because that was the way to save our lives and those are the people around us. And as health professionals, it was essential because otherwise we were putting our patients at risk. And then within a year or two, it turned out that that narrative had changed and it was really just to try and reduce symptoms. So the difficulty is if one changes the message, then that doesn't help the argument, I think. But that's a personal view. With respect to the HPV vaccination and anti-vaxxers, my observation is it's a continuation of the same thing. The people who don't want their children to be vaccinated are the same people who just generally don't take on board or believe that it's in the population and in their family's best interest. Ultimately, there will always be 10 to 15% of people who don't avail themselves of the things on offer. I don't feel that there's anything we can do about that other than continue to provide the information showing the benefits, showing that the risks that they perceive and are fearful of are unfounded, and to try and provide the correct information. I don't think that there will always be a cohort of people that we're not going to persuade to our preferred view. That's the world.
Yeah. Yeah, we did have these. I mean, for a few years it was not there, this problem, but then the last year, a few months ago, there were some anti-vaxxers who were actually giving some actually sending legal notices and things like that. But fortunately, yes, there was there's I think there is confidence amongst the doctors as well about this.
Yeah, no, I generally there hasn't been that sort of severe or stringent a campaign against vaccination or HPV vaccination in particular that I've been aware of in this country, though there are pockets of it, as I say.
Yeah. So so you are seeing the benefits of vaccination over so many years. So you are seeing changes,
Definitely,
decrease in
the data coming out in the last 2 or 3 years, so even for those of us who, when the vaccine program first started, we said, well, it started a bit quick, we haven't got enough information. Everything over the last 15, 16 years shows that if you are in the vaccinated cohort, as I've said already, you're less likely to get high-grade CIN, you're less likely to get cervical cancer. They're now starting to look at the information, and particularly since we started vaccinating boys, so it's now a gender-neutral vaccine. Personally, I think that is very important, and hopefully will also make a big difference in people's perception of of the place of the vaccine. And in the most recent campaign, there was a steer slightly away from purely cervical cancer, but also now starting to talk about its prevention of head and neck cancers and its prevention of other lower genital tract cancer, and anal cancers. And so I think that it was interesting. I read an article about specifically moving the campaign more to head and neck, because then there's less discussion about or concern about promiscuity and so on. So making it gender neutral by saying that other areas and this vaccine can help prevent against all these HPV related cancers, not just cervical cancer or penile cancer, seems to be having some sway. But I think it's too early to evaluate that aspect of it.
Right. Right. So you've now, regarding the screening for these women, or screening in general. So the screening is now with the HPV. Have you shifted to HPV testing?
Yes.
Or is it?
Yeah. So in the United Kingdom, in all of the countries except Northern Ireland, we moved to primary HPV screening in 2020. Northern Ireland, there was a delay because of the breakdown in the Stormont of their local or their regional government. So their healthcare had much bigger challenges over the last few years until that has now been restored. So they're playing catch up. But broadly speaking, we all offer HPV primary screening from the age of 25. And then again, in terms of the variation, so in England, we still screen women between the ages of 25 and 49 every 3 years, and then from 50 onwards, if everything's been clear, every 5 years. Wales and Scotland have already screened everybody every 5 years. England, I am told, will be increasing the screen interval to every 5 years, I think later on this year, but it was predicated on our IT system for the country, which was very old, and now we have a new one. And that goes back to, I think, when we started the discussion, my trying to explain that linking the vaccine status of people to their screen history was not possible prior to the new system that we now have in England anyway.
Yeah, so what in the vaccinated population, are they any different in the HPV types that you're saying? Is there any, you have that information on that?
So in terms of the overall data, the Scottish data shows that there is a decrease in HPV 16 and 18, as one would expect. But there's also some cross protection. So there's also a decrease in those with HPV types 31, 33, and 45. That's from their data. Our program, in terms of the primary screen test, we don't have subtyping, so we don't know. So a woman, there are 4 HPV labs across England, and some of us use slightly different systems. So the London area, which accounts for 20% of screening in the country, we use HPV RNA and Abbott. Other areas are using Roche and the DNA test. So there are slight variations there. London opted for the RNA platform to try and reduce the numbers of women coming in for colposcopy, because it's slightly because it's looking for integration of the virus rather than just the presence of it. So the idea being that it's slightly more specific. So time will tell whether that was the best, but that's what we have done. And sorry, I've lost track of what the question was. So that the plan for us, we haven't changed the program dependent on whether a woman is vaccinated or unvaccinated. So I think that may come in future, but that's not currently in the thought processes. First, it was get a system where we could actually link the data. Now it's sort of have all of the countries of the United Kingdom offering the same screen intervals in terms of cost effectiveness and the evidence that shows that 5-yearly is perfectly safe and sound. And our other struggle or challenge is actually coverage. So coverage for women attending for screening in this country is a significant problem. So it has dropped below 70% in the last year. And as you know, if we're not screening at least 70% of the population, the program cannot work. And they still need to be screened. So that message of just because you're vaccinated, don't forget you still need to be screened. I think we need to do some work on that message.
Yes. So how was the, response with when HPV testing was introduced? What was the acceptance?
The acceptance was fine. I think part of there wasn't really any issue. So maybe we're just a fairly obedient lot. I don't know. But when people get their letter, they by and large attend. As I said, with that caveat that overall coverage has dropped. So that's a concern. The change to primary HPV testing has been a challenge for colposcopy units. Because when it first came in, obviously you have quite a large cohort of people with the presence of HPV. Our program is so that if you have HPV, and in the lab, they'll do reflex cytology. If the cytology is normal, then that test is repeated in the community a year down the line. And if that's still the case, then they have a further test in the community. So you have 3 successive tests over 24 months before you get referred into colposcopy, in the hope that it will have cleared and everything will settle itself down. But otherwise, you then get referred in. Between that cohort and the borderline low grade, there's overall all colposcopy units saw at least a 30% increase in referrals. And the Scottish data also shows that with the change of the program, you get these peaks and troughs. So you get dependent where you are from when you start. So trying to sort of cascade it rather than, oh, this is the cohort and they all get their vaccine now. So trying to think of ways in which it's staggered, that's the word I was looking for, rather than I think is important in the planning, because otherwise you get a huge wave of people all needing to come in, and then you get a bit where there's not a lot going on and everybody says, oh, we don't need colposcopists anymore. And then as we are now, we haven't got sufficient colposcopists for the, for the workload.
So one more question about vaccination is, how about which age group are you targeting? Is it all till women till 45 or only the 9 to 14?
No, so within the National Health Programme, so youngsters from the age of 12, so it's year 8, boys and girls. So that's the age group that is invited. And then there still is a catch-up up to 18 within schools. Everybody under the age of 25 remains eligible. So if they haven't been vaccinated and they wish to be vaccinated, they just need to make an appointment with their GP to arrange it. And that's still available to them free of charge. So some people so, for example, those who may have been vaccinated with either Cervarix or Gardasil 4 and want to have Gardasil 9, they're not eligible under the free program. But if they wish to pay privately, they can do. And the vaccine is available very easily in most local pharmacies these days. They can make an appointment for a consultation in the pharmacy, and it's organised privately. The other NHS considerations. So if you are a man who has sex with men, the transgender population, so again, they're eligible up to the age of 45, but it's more difficult for them. It's usually via one of the either sexual health services or some other route rather than necessarily the GP. And if you are immunosuppressed, or it is thought, that on a case-by-case basis that you'd benefit from it, then it is also available. But one has to make a case for that for it still to be free. And our dosing is, so since 2023, it's a single dose for boys and girls and people with a cervix who need it. If you're over, if you're 25 or over, then it's 2 doses, 6 months apart. And if you're immunosuppressed, then it's the full 3 doses.
Yes. So, but with the Gardasil 4, I mean, you have the single dose. You giving this Gardasil 4 with the single dose, or even Gardasil 9, because we don't have data yet for the Gardasil 9.
Yes, no, we don't, but we're now giving Gardasil 9, so we'll have to wait and see. So, but that's only in the last. I was looking it up. It's only in the last year or so that we moved to Gardasil 9. Because after COVID, there was also a production issue. It was difficult to access.
Yes.
But yes, we'll have to wait and see the data.
So 9 to 25, you're giving single dose of Gardasil 9. And after that, it is 2 doses.
Yeah.
Yeah. Okay. So, and Teresa, what do you think? I mean, what message would you give for the gynecologist, and how do you think we should be approaching the vaccine, the women about counseling for vaccination, the girls, and for screening? There's a lot of, when you talk about HPV for screening and you find them they're positive, then there's a lot of questions in their minds, and where did I get this infection from? So which is,
Yeah, no,
so
I
that
I
caused a
agree.
lot of
I
anxiety and
I find in my clinics that since we've had primary HPV screening, there are a couple of things that I reflect upon. The women, when they come, are more anxious about the HPV than sometimes, even if they have got a severe abnormality. They are less bothered by the severe dyskaryosis, which is the thing that's worrying us,
yes.
than because of our concerns about cancer. They're more concerned about the HPV, how did I get it, and so on. I think that we need to be better at trying to convey that message. So when people watch this, 80% of the people watching this have got HPV or have had HPV or are going to get HPV. It's just a reflection of sexual activity. It's a reflection of being human. It's quite normal. And some of our health professionals haven't understood or got that message. I think that's less so amongst people who are looking after women or obstetricians and gynecologists. So I'm talking about fellow health professionals, I'm talking about general practitioners and so on. But I think that is the message that needs to be understood. Having HPV is just, well, that's just life. It's more what one's body is going to do with it, how our immune system is going to clear it, that becomes an issue in terms of their risk. So trying to get that message across, I think, is important. And that's by and large, day to day, what is the message I'm trying to convey to patients and to trainees and residents when they come along. So I think that's the key, moving away from it's a sexually transmitted infection. This happened and that happened. We've no idea what happened. Everybody's got it. So we just have to, accept that having it doesn't even mean that you're necessarily ever going to have a problem. It's just that now we've got a more sophisticated test that we can see it. And now that we can see it, and we have colposcopy, we have secondary screening, we have treatments for abnormalities, there's something we can do about it. And in the fullness of time, I suspect there'll be something we can do about, well, even in the non-vaccinated cohort, about trying to boost people's immune systems to perhaps clear it. I don't know if you've come across the work of John Dauber here in the UK, looking at the concept that it's not even that it's cleared. So even our language is out of date. And in that sense, what he is saying is that one gets our HPV, and yes, we may not be detecting it, but it doesn't mean to say that it's not there. It's just in such a low level. And then as we get older and our immune systems become less good, then it may come to the fore again, and that may explain. So it may not just be that you've reinvented yourself or necessarily got a new partner or your partner's done anything. It may be purely a reflection of the changes in our own immune system as we get older, that it comes to the fore again. So I think those are all important messages to understand, and not to be judgmental as far as humanly possible, because at the end of the day, we all have HPV. We've all had HPV at some point, or we may get it. It's intimate skin-to-skin contact. It doesn't have to be penetrative sex. So getting around and getting away from all of those concepts, and then just thinking, well, it's a way, if we know that you have it, then we can look for some other markers. And if we treat these pre-malignant conditions, we can prevent women getting cancer. That's the bottom line in our world. And similarly, if we think about other lower genital tract and HPV-related disease, increasingly, hopefully, that will be the case to reduce those cases and the morbidity of them.
Yes, absolutely. So I think it's really important that the right message goes across to all the women who are coming for screening.
And yes, and also so that they don't feel, because that's the thing. I'm sure you've had that experience. So people either feel that their partner has done something and that's how they got it,
Yes.
and some feel guilty because they feel they may have done something and that's how they've got it. But it's nothing to do with any of that. It's I would suggest quite a random thing in many ways. It's just, a bit like we have 200 viruses in our nose, and when we're tired, then we run down, we get a cold. So we have HPV. If our immune systems don't clear the virus using old language, but you know what I mean, then then it might integrate into the cells. It may cause some dysregulation of the cell cycle, and it may cause a problem. And so then we do our best to try and deal with it.
Also,
That's
you may be having
what
the
I mean.
women who have been vaccinated and then having maybe some HPV virus types detected. So
Yes, I mean, I think we have
Yeah.
to wait and see. The other interesting thing for the future is that now that we have less HPV 16 and 18 types, I think our colposcopy findings, they're more nuanced. So you don't necessarily always get those clear standard patterns that we talk about all the time, which we saw when there was a lot of 16 and 18 around. So I think sometimes you don't get those overt changes all of the time with some of the other viral types. So there are other innovations that we need to come up with to be better at detecting.
Yes.
So
Yes. So, what is your message to the gynecologist for
well, my message to gynecologists is carry on with all the good work that you do, because it's hard, and we all have lots of other constraints. When you think about it, cervical cancer prevention is hugely important because it is preventable. There is something that we can do. And so therefore, going ahead to do that, to encourage people to be vaccinated, to get people to still attend for screening, to have better ways of offering treatment and reducing morbidity. But one has to remember, against the giant scheme of things, there's a huge number of responsibilities that we have as gynecologists. I don't do obstetrics anymore, but the world there is and reducing maternal mortality. My take-home message is that since I became a consultant now 24 years ago, maternal mortality has decreased, but cervical cancer incidence and death has not. It's increased. So therefore, it behoves all of us. We all have a responsibility to try and reverse that trend, because it is reversible and we can do something about it. So that's why we're having this discussion.
Yes. So as the president-elect of the International Federation of Colposcopy, and cervical pathology, what is the vision for the entire world?
Oh, the vision for the world. I'm not quite ready to take over the world as yet. But I think the vision for the International Federation is the importance of that collaboration amongst the countries that are members, those that are not members but wish to be, and that we have a common language, because that makes it easier. So I would say that our focus is on the education and training of health professionals, of doing our best to facilitate that education and training to the wider public, to promote the advantages of vaccination, screening, and the treatment of pre-malignant disease. But if you say what our main focus is, clearly, predominantly we are colposcopists. So I would say that it's really important that when people are coming up with their plans and their strategies, not to forget vaccination will do so much, and it will do a huge amount. It will reduce the incidence and hopefully deaths by 80 to 90% for sure, but it won't do it all. And there will always be that unvaccinated cohort. And our job is to do our best for both the vaccinated and the unvaccinated to treat pre-malignant disease and prevent people getting cancer. That's our remit, and anything we do in terms of education programs, training programs, making sure that our standards when we're doing excisional treatment or ablative treatments fulfill the criteria to offer all women, all people with the cervix, the best that we can, then that's our remit. That's what I see as the remit of the IFCPC.
Thank you so much. Thank you so much, Teresa, for joining us and sharing your valuable experience and the advice that you've given for all of us. So that's really important, and I think we will be looking towards you. We'll be seeking your advice more and more in future.
Well, likewise. Anyway, thank you very much. Thank you for the opportunity to chat and to catch up with you. And also to Dr. Sunita for coming up with such a brilliant idea.
Yes, yes. Thank you so much, and thank you, support team. And have a good night.
Thank
A
you.
good evening. Thank you.